Michele, what was the turning point that led you to become a life sciences investor and operator?
Well, yeah, I started an interesting mission for the Italian Confederation of Industrialists to take my experience as general manager at IBM to the benefit of the medium and small enterprises in Italy in order to generate innovation and new businesses. One of the sources of innovation is a traditional university, and I started creating a scouting program with some of the most important universities in Italy to generate ideas that could be transformed into projects, projects into companies, and company into scale-ups, and eventually unicorns. In that process, I started meeting with very good scientific leaders that turned out to be my co-founders in a number of both biotech and medtech ventures that I funded initially. And then with that experience, I started leveraging my own capital through my family office to build and support other ventures where I aggregate other private investors and venture capital funds in order to reach their goal.
All right. That's a very interesting story, but we'll dig back more into it later. Welcome back to How It's Med, the podcast in which we chat with those shaping the future of healthcare and health tech. My name is Jeff, and on this podcast, we hear from leading investors, startup operators, and occasionally an ex-general manager of IBM Global Services so that you too can learn from their stories, secrets, and skills so that you can be better equipped to make a positive impact on the lives of others through healthcare and health tech. This time around, we're joined by Michele Marzola, currently a lead investor in many medtech startups, but most importantly for today, the co-founder and chief executive officer of XSurgical. Michele, how are you doing?
Well, yeah, we are doing pretty well in many of my portfolio companies. We're progressing on many fronts in my drug development activities in oncology and in medical devices. XSurgical is one of the most important of my medtech ventures, where we are building the surgical robots for the next generation of applications, going beyond the limitations of the Da Vinci robots and addressing new markets such as the open field applications for the mission critical situations, such as battlefield or civilian emergencies.
Honestly, I have no clue how you do so much and also do it in what you mentioned was the 38-degree weather of Italy in the summer. So congrats to you. But I generally like to dig a bit into the background of the people who come on because it's our histories that inform the actions that we take in the present day and in the future. Your pre-life sciences career was very much steeped in consulting.
Yeah.
Why did you choose to go down this path? And how did it add or take away from the difficulties of entering the life sciences field?
Well, in fact, so many things that happen in life are more due to the opportunities that you find on your path than on rational choices. So I made the rational choice when I finished university to go for, I did my PhD in mechanical engineering, and then I went to do an MBA at Columbia University, and I made a conscious choice of creating my academic path to become one of the top management consultants, which I did. I had a very fast career, becoming the youngest principal at Booz Allen and Hamilton in the 80s. And then I became also one of the youngest vice president at IBM at age of 35. So those were a rational path toward a career in large multinational firms or top consulting firms. The change toward life science has been due more to the opportunities of meeting my current co-founders, professors in immunology, professors in robotics, um, great co-founders in various disciplines. And then I developed a taste for investing and developing companies in life sciences, where I have to say it is a marvel how we can combine human ingenuity with science in order to arrive to radical changes for the better outcome for the humanity, because developing new therapies for oncological problems, for mental health, for surgery, for orthopedics is something that changes the lives not to the few hundreds, but to the few millions. So that's a very important thing to me.
Yeah, that's fair enough. I see how your background in engineering and then management consulting with your experience in M&A could have a very, I guess, informative impact as to how you approach the deals, the life sciences deals and companies that you work with now. So certainly they help smooth the way. Did those previous experiences provide a challenge, at least in terms of a need to shift mentality at all when coming into the life sciences startups that you're now involved with?
Yes and no. Any management experience helps when you apply it to life sciences. It is, I'm certainly using a lot of my initial experiences in strategic thinking, in competitive mapping, in developing scenery, a scenario for the future evolution of a company, and also in the financial details of what it takes in terms of funding, leverage, potential outcome in order to create the maximum value for the companies where I invest. On the other hand,
Hmm.
life sciences is a wonderful setting for creative thinkers because there are so many variables in terms of what you can develop as new therapies, new applications. The competitive landscape is continuously evolving. Um, the financial side needs a lot of creativity in order to have the right mixture of funding and the creation of value at each stage of funding in order to continue to grow with your path toward an exit. So nothing
Hmm.
peculiar of life sciences, but certainly it's plenty of very promising perspectives that we try to capture in every venture where we invest.
That's fair enough. One of the most interesting experiences that you have or that you had before you joined your work with life sciences sector was your work with IBM. What were your most cherished experiences during this period of your work, and how do their impacts continue to reverberate through your work today?
Well, at IBM, I had an interesting mission of developing a consulting entity, so a professional service within a large corporate. And I've been able to shape new rules and new processes that were compatible with the traditional processes of a large manufacturing company like IBM was at that time. And that creativity permitted to develop new leadership experiences in the global services division, where I took a very large responsibility leading businesses for several billion of revenues every year. That's a top management experience that I'm trying to apply in terms of vision and discipline, also in life sciences. And any company that would like to be a large company needs to know what it means to be $1 billion company in value and in revenue. And this is sometimes lacking in life science startups. And I'm trying to instill this vision and discipline. So, on the other hand, other things that I've done and that I'm very proud of at the IBM time have very little applications in life sciences. I've been one of the initial inventors and authors of intelligent networks and smart cities, smart grids, and that's an opportunity which I created at IBM, and then has basically no application in life sciences, but so be it. It's a different part of the life and different experiences.
That's super interesting. Your work really is diverse in its nature overall. But as we mentioned in your work with, I guess, an innovation group for industrialists in Northeast Italy, I believe it was,
Yeah.
you've managed to pivot your way into life sciences. Who are the most interesting people that you met during this initial foray into life sciences, who then informed the key ventures that you've pursued since?
Well, certainly some of my co-founders. Um, One of the greatest co-founder I have is Professor Marco Colombatti, professor of immunology at the University of Verona. Extremely competent in his domain, clearly being a professor, but with a great vision on how the science can evolve, and an extremely good co-leader in businesses, because he always knows when he needs to lead and when he needs to follow. And we work seamlessly and in a very complementary way. Other experiences with academic co-founders have been less successful, and sometimes it is difficult to instill the business needs in the minds of academic professors. One of these professors once told me, you cannot dictate the timing to the science. And I said, yes, but when you have a burn rate of 100,000 per month, you need to know how long it takes to develop a new blueprint or a design, because I need to provide 100,000 every month. And if your science takes 1 month is 100,000. If it takes 10 months is a million. And if it takes 100 years is impossible. So it's, so there are always interesting learnings that you do in meeting with scientific co-founders.
Mhm. It seems like that's a common problem everywhere in academia, because academia is so much focused on getting the result, I guess, separate from the limitations to some extent of the economic bounds of innovation that occur in bringing a product to market overall. But we first met, or we first interacted, when you told me a little bit about XSurgical. So, how did the story of XSurgical come together, and how did it tie into the narrative that we just talked about there, with academic founders being either easy or difficult to work with in starting an amazing new company for?
Well, this is an interesting endeavor that actually started with the work of one of my co-founders at the JPL laboratory in California. At JPL, which is part of NASA, they developed a robot designed to fit on a spacecraft, with the ambition of giving terrestrial surgeons the possibility of intervening on astronauts if anything had happened during a long distance journey, like the mission to Mars. Whether that's was going to be a sensible proposition or not, considering the time lag of intervening with the signal, especially when the spacecraft were to be around Mars rather than nearer to the Earth. That could have been a debatable thing. Anyway, in a typical top technological development, the JPL laboratory developed this very small robot designed to fit in minimal spaces because the spacecraft are not large. And that minimal robot. We took the concept, licensed the technology um, from uh, California University, and we developed and applied that very small robot for terrestrial utilization in normal hospitals, developing specific tools in order to make it effective, and we used it very effectively on animals to do the resection of pancreatic tail, which is one of the most challenging surgical procedures for saving patients from, for example, pancreatic tumors. Um, it worked, but still being very small, was able to operate only in one of the four quadrants of the abdomen at a time. So we adapted the design in order to have a larger robot capable of operating on the entire abdomen, which was the beta version after the alpha, clearly. And that robot was CE marked, so it was freely qualified for the utilization in Europe. Still very complex and still capable of operating only on soft tissues like the abdomen. So we have then developed the gamma version, which is designed to operate on the entire body, capable of operating on soft tissues and hard tissues in order to have a single robotic platform capable of delivering all the procedures that a normal regional hospital need. And the regional hospitals do not have that number of patients with the same pathology that would justify buying several robots for several procedures. They need one robot that needs to do as many procedures as possible in different departments, and this is exactly what we have developed our Gamma at XSurgical.
Mhm. When we last chatted about XSurgical, one of the really interesting things that you talked about was the democratization of surgical robotics. Why is this such an important aspect of the work that you do and your team does at XSurgical?
Well, we can certainly say that robotic surgery has improved the outcome for patients and the safety of surgical procedures. This has been demonstrated during the past 10, 15 years in abundant number of patient cases. We know that a large part of the surgical incidents depend on the bottom 20% of surgeons, and robotic surgery permits to have supervision, training, in order to enable a much more predictable outcome, even in the hands of the less gifted surgeons. In addition, the dexterity, scalability, and operability of surgical robots have demonstrated the capability of doing better procedures for many patients. Unfortunately, all this has been true only in 6,000 top urban hospitals in the world, and only those patients that can go to those locations are able to get the benefits of surgical robotics. Furthermore, only those surgeons that operate in those top 6,000 hospitals have the possibility of using the additional features of robotics. But they need to do it with the tools and devices that are provided by the robot manufacturer. All these robots are closed, have a closed architecture, and the surgeons cannot continue to use the tools and devices that they prefer because they are not allowed to be used on the existing commercial robots. So we are trying to do two things to democratize access and benefits of surgical robotics. First, with a universal platform, to be able to serve the other 45,000 hospitals, so 10 times more than those hospitals that are currently served, that would require a more flexible and economical platform to be economically operated in regional hospitals. This will open the opportunity for millions of patients to get the benefits of surgical robotics. By having an open architecture, we are also enabling those surgeons that want to keep using their preferred tools and devices to do so, because we will adapt in our robotic actuation to the specific features of tools and devices in order to let the surgeons do the procedure in the way in which they think it will work best. Furthermore, our system is teleoperable from the onset, which means that even in regional hospitals, they can have the benefit of having procedures supervised by the top surgeons living and operating in large urban setting, but being capable of be there virtually with a number of our artificial intelligence tools and devices that will permit to compensate the time lag, even with intercontinental operations, like we have successfully demonstrated with an orthopedic procedure where the surgeon was operating in Milan and the mock-up patient was in Boston.
Mhm. There's so many questions that I want to unpack from there, but you ended off on the use of AI, so let's dig a bit deeper into that. One of the applications of AI that you mentioned with XSurgical is to compensate for time lag. Um, can you dig a bit deeper into specifically how AI is used to compensate for that factor and what other applications could possibly be implemented with the platform?
Yeah, sure. Well, um, my co-founder, Professor Denovi, is an expert in artificial intelligence applied to medical devices. So he's the main author of our artificial intelligence applications. One of the manifestation of these applications is the capability of predicting which tissues will be hit by the tool once the motion is going to be applied. So we know from the beginning what is the time lag between the operating station and the actuator, bearing in mind that anyway there will be a local operator in the same operating room anyway. In any event, once you measure the time lag, even for intercontinental operations like we did Milan to Boston, then you can predict, according to the initial motion, where the tool will move inside the body or anyway on the tissues of the patients. And with the modeling of the surgical theaters, we can create boundaries that cannot be um, trespassed in order to increase safety, because that would mean saving blood vessels or nerves or any other potential difficult locations. And that will enable the remote surgeon to move with a safe boundary and continue to operate safely to complete the procedure.
Mhm. Another important aspect of the, I guess, little speech you made before about X Surgical and what separates it from the competition was the implementation of compatibility. with third-party surgical instrumentation.
Yeah.
You mentioned that this is unique to XSurgical. Why
Yeah.
take on this unique business decision when other companies have chosen not to do so?
It's part of the concept of democratizing the access to surgical robotics. It would have been much easier for creating a positive business case for us to say, oh, we are doing like anybody else. You need to buy our tools and devices. We'll disable our tools and devices every 10 times you use it, disregarding the actual duration. And um, and that would have created a captive recurring revenue that would have been easier to forecast and to propose for the financial market. But this is not what we think patients will need and regional hospitals will require in order to buy a new surgical robot. So it is a conscious decision to arrive to a broader market with a more affordable proposition where we will be happy to get our licensing royalty for the uh, software development kit that we're going to give to the third-party tools and device manufacturer in order to enable a better utilization of their tools and therefore of the number of procedures that we can execute with our robot and consequently for the regional hospitals to have a much better utilization of an expensive asset that they will buy, and that will enlarge the market, in our opinion.
Mhm. I understand how that leads to increased democratization as well as for local developers to meet the needs of a hyperlocal, I guess, hospital, for example. But what are the risks and perhaps downsides afforded by this decision? Obviously, one of them is a lack of ability or decreased ability to forecast revenues. But what other risks are introduced by this unique decision?
It's from the financial point of view, our business case is based on developing revenues out of about 100 units to be sold, which will grant already an acquisition from one of the industry players for a valuation which traditionally in this sector is between 1 and 2 billion in aggregate value. So it will be more than enough to give a strong return to our investors. So there are no other particular risks associated with this policy of being an open platform because we will qualify the utilization of third-party tools and devices before they are released for the utilization on our platform. So everything will be in line with traditional clinical and quality control, and I would not foresee any particular risk beside the predictability of revenue generation, frankly.
That's fair enough. We mentioned two important aspects of X Surgical that allow for it to democratize robotic surgery overall, but developing a robot that does surgery in collaboration with a literal rocket device laboratory is not a simple endeavor. What are some of the struggles that X Surgical has faced? How has it overcome them? And where specifically in its timeline is the company now?
You are absolutely right. In all my ventures, I can certainly tell that surgical robotics is the most complicated of them all. You have all complications of clinical development, technological development. The IP scenario is extremely complicated because Intuitive Surgical, the dominant player, has basically patented everything, including the sun and the pizza even if it has nothing to do with surgical robotics, but they've been able to patent everything. So the patent landscape is not easy. We've been able to develop 4 patent families in our area development, and we plan to do new patents around our field operations and also for our normal emergency room applications. So the challenges are all there, and it is not easy. We are 3 competent co-founders bringing together very deep domain skills in robotics. Also, Deborah Botturi, the other co-founder, is a PhD in robotics, and we have the business experience of Gianluca and myself being serial entrepreneurs. Deborah is actually working today for one of the major tool manufacturers in the surgical industry. So we're well equipped, but clearly we have to complement and strengthen the team, and the capital raise that we are doing is exactly meant to have the funds necessary to complete the team and complete the first 2 prototypes that we will be using for regulatory purposes.
Mhm. You mentioned the deployment of the surgical robot to battlefield settings in such an austere setting. What's the case for using such an intricate and, to be frank, often high maintenance piece of machinery?
Well,
Isn't
it is.
the use of basic human hands more reliable overall?
Well, in fact, it is. There's only a little detail. Normally, military surgeons despise having to defend their lives battling with enemies while trying to save the lives of wounded soldiers. So, a military surgeon would feel a lot better to be in a safe haven, probably a few miles away or 20,000 miles away from the point of injury, and being dedicated only to saving the life of the wounded soldier instead of battling for his own life as well. So, this is the dream that the Department of Defense has had for many years, and we are developing our battlefield and civilian emergency version under those auspices of finding a way of intervening on a very harsh environment, like really on the battlefield, on the point of injury, with a robot that could be light enough to be deployed by hand by 4 paramedics on a normal military vehicle that can be assembled in a matter of minutes, even in trenches that could operate with unreliable power sources. We have considered to put the power source on the base of the operating bed, with all sorts of visual devices that would give to the remote surgeon both the overall vision of the theater of the wounded soldier, as well as all the laparoscopic cameras in order to operate on laparoscopy if necessary, or very likely on the battlefield on open surgery, in order to be quick on saving the life of the soldier, blocking hemorrhages, or intervening on broken limbs in order to limit the future damages that the soldier can suffer. So
Mhm.
this is the objective, and then we have different level of deployment near to the point of injury. So one of the easiest is to deploy our robot in tented hospitals, so the typical field hospitals for military purposes, which would be a lot nearer than a sterilized operating room to a military operation. So, and this is certainly an interesting challenge from a technical point of view because we have to design a robot that can operate from, in terms of centigrades, from minus 20 centigrades to plus 70 centigrades in order to be able to operate on Arctic deployment as well as in desert operations under snowstorms or sandstorms with a number of tools in order to use the tools only on the single wounded soldier for that mission, and then to go through the sterilization back when taken back to the home hospital of that robot. So,
Hmm.
very good challenges, and we are very happy to be able to solve a good number of these problems.
I've got two follow-up questions to that. One is that you mentioned previously that XSurgical's robot is able to operate in both less dense tissues, so say the abdomen, versus more dense tissues, such as in an orthopedic setting.
Yeah.
What are the limitations posed by this flexibility, or perhaps you could say by this lack of specialization?
Yeah, no, in fact, this is the typical difficulty in any new product development of looking at the value of variety versus the cost of complexity. We have solved it with the design of the robot being a robot with up to 4 operating arms. The arms are designed to be strong enough to operate on bone tissues, essentially, so for neurosurgery and for orthopedics. So the strength of the power of the motors and the rigidity of the arms is possibly excessive for operation on the abdomen, but this is part of the embedded cost of the robot, which is not going to be excessive compared to the current Da Vinci product line. So there is a potential slight increase in cost, which is not an increase in price for pure soft tissue operations, but with the advantage of using the same asset on any type of tissues in the human body. We are not trying to operate on eyes, but we can work on any face operations. So we are not trying to go into the retina or any specific eye surgery because that's a very tricky one. But we have the precision to adapt our robotic actuation to any laparoscopic procedure that can be remotely operated, as well as being capable of doing all the hard tissue penetrations, for example, for operation in neurosurgery, or for example, total knee replacement, where you need to have the strength to operate on cutting the femur or the tibia in order to implant the new artificial knee implant.
Hmm. I think the other question that inevitably springs off of that quote that you gave with regard to the robot having 4 arms is, what has the surgeon's feedback been to the development of the robot so far? I'd be really interested to hear what they think of the flexibility of this platform, but also of needing to use multiple different arms to accomplish the same objective in multiple different settings, whether or not it's in a
Yeah.
remote setting or whether or not it's a different setting in the body.
Well, first of all, our configuration is modular, so we can operate with up to 4 arms. But there are simple procedures such as guided biopsies, where you may do it with only 2 arms, one with the camera and one with the tool for the biopsy. So it depends on the procedures, and the hospital can optimize the cost and the utilization by setting the operating room or the operating field with the number of arms necessary for that procedure. We have had the fortune of having Dr. Wayne Paul, one of the successful surgeon who has operated on several surgical robots, as well as being an entrepreneur himself, developing his own medical device company, overseeing the development of our Gamma, and he praised the development of Gamma very positively. We have also recently engaged a new advisor, Dr. Arnold Korngard, who has been one of the first to apply the Da Vinci robot on prostatectomy, the most important and still the largest application of the Da Vinci robot. And he also liked very much our approach, and he has actually been one of the first authors of creating shareable surgical robotic opportunities, which is one of our themes of enabling regional hospital to afford surgical robots, because they may even pool their interest with 2 or 3 nearby hospitals, and having the robot on a trailer to be deployed a couple of days per hospital during the week.
That makes sense. To I guess backtrack a little, your work in life sciences is very diverse, but I noticed it mainly focuses on therapeutics and devices only. This is a trend that's contrary to the glut of digital health and medical software startups that are forming and beginning to enter the market now. Why did you make this choice, and what are the barriers to entry to and difficulties associated with entering these more capital intensive fields?
Well, see, it's a long story because we had any investor, be it a VC fund or a private investor, has got its own investment thesis. And my investment thesis is that I invest where I see 2 factors at the same time. One is if we succeed, will it make a difference? And if we have to develop beautiful digital health things that will just increase the number of times you look at a monitor and knowing a little bit better your health, it doesn't make a difference to my count. Developing a drug that will solve prostate tumor or ovarian tumor or developing a solution for treating depression in a much more effective way is something that will change the life of millions of people, and this is where I engage. The other criteria in my investment thesis is that I will never really invest time if I do not see the possibility of a 20-time return for myself and for my co-investors. And at the end of the day, if you look at many opportunities in digital health, it is rather elusive to think that you can get a 20-time return. In my opinion, there is no free lunch in life sciences, so you have a very hard gain if you take very hard risks. And the hard risks are typical of preclinical development in drug development, where you do all your due diligence on the quality of the science developed so far, the potential evolution of that science, and the potential impact of that therapy if we were to be successful. It is the same in medical devices, where you can gauge the potential impact of a new medical device if we succeed in delivering the benefits that we are envisaging and designing. all the time that I looked at potential investment cases in digital health, I've been very lukewarm on the potential impact and even on the potential return. So I'm very happy to leave it to many other investors that have digital health among their preferences and concentrate on the domain that I prefer. Same thing, unfortunately, on diagnostic. I like diagnostic conceptually. I think we can make great progresses on diagnostic, but it is very, very hard to have follow-on investments in diagnostics. So I've abandoned diagnostic unless it is for companion diagnostic on my drug development companies. So this is where I'm concentrating because I see the possibility of the two key objectives to be achieved at the same time. Great impact and 20-time return for our investors.
That's super interesting. Um, we don't have the time to go through all the work that you do as a lead investor or otherwise in various companies, but you continue to do some amazing work outside of X Surgical. What are the three projects of yours that excite you the most?
Well, there are many. So just to follow on the discussion on mental health, we are very excited about what we are achieving at Soma, a company based in Finland where I'm a lead investor. The company is the emerging leader on a treatment for depression, chronic pain, and migraine called with a technology called transcranial direct current stimulation, where we have a solution which is totally non-invasive, which permits to deliver a very feeble direct current in the brain to stimulate the part of the brain that affect those syndromes. And with a treatment that lasts about 40 minutes per day, 5 days a week, in 1 month, we have been able on 10,000 patients to make all of them much better off at the end of the first month of treatment without any invasiveness, without any side effect. And we are the only one which is approved as a medical device and that can deliver the treatment at home, increasing compliance, reducing cost. And we're able to get people out of depression, even starting from a very deep depression, in 1 month with a cost per user, which is less than $500 per patient, which is about 1/10 of an alternative treatment called transcranial magnetic stimulation, which requires hospitalization every day. So that's very exciting. We are raising a Series A of 5 million, and I'm certainly very interested in talking with potential investors willing to join us, even with small ticket items, together with other family offices, both in Italy and in Finland. The other project that I would like to talk about is my own biotechnology company, where we are developing a solution for 5 solid tumors, prostate, bladder, pancreas, stomach, and colorectal tumors. This is the company that I founded with Professor Marco Colombatti, and we have designed a novel antibody-drug conjugate, which combines two fragments of antibody, seeking at the same time two antigens, fused together with a toxin. And on the animal model, we have shown the capability of reducing tumoral mass by 75% in a month without any side effect, and with a very limited dose, even though we have not observed any toxicity. Anyway, the toxicity would have been extremely low because we are able to take the toxin within the tumoral mass, and then the toxin unleashes an enzymatic process that keeps eroding the tumoral mass for at least 10 days, making an incredible exponential effect in terms of toxicity injected versus tumoral mass destroyed, compared with the current ADCs that at the end of the day are limited by the stoichiometric ratio of the toxicity injected to the tumoral mass destroyed. So these are very exciting projects where we are working and trying to get all of them to the line of delivering tangible clinical outcome and hopefully then to be acquired for a lot of money.
That's fair enough. It's really fascinating that you're involved in so many different fields in life sciences overall, each with, as you said, the potential to make massive impact on problems that are quite severe and not necessarily as well addressed as we'd like. Um, I tend to ask this question to everyone who comes on, but beyond these amazing projects that you just mentioned, are there any new projects that you're working on, or as I say, any pluggables to plug that you'd like to share with the audience of this podcast?
Well, for sure. There's always the next investment which you think is going to be the smartest and most beautiful that you are going to accomplish. In fact, we have been working on a new investment in a French company named Sikyo, SEEKYO, and the company is also drug development in oncology. They have an incredible formulation which permits to deliver auristatin as a tumor killer only when there are necrotic part of the tumor that basically unleash and creates the separation of the linker. They've shown animal models with regression on pancreatic tumors up to 85%. So even better than my own intercepting on pancreatic, but I'm also addressing other four large important tumors. So I'm still keeping a strong development there. And at CKO, we're going to create a consortium with other investors in Europe without revealing anything more. And we are about to close the consortium during this coming fall, and that will be an interesting new endeavor where hopefully we will take the experience that we have developed in other five drug development projects in oncology.
Mm-hmm. All right. Well, thank you so much for coming on, Michele. I really appreciate the time.
Well, thank you, Geoff, for inviting me, and it has been a real pleasure to share some of my thoughts and experiences in life sciences. Thank to you and to all the people participating to this webcast.